Good afternoon, sir. I'm going to present a short case. My diagnosis is case of bilateral primary osteoarthritis of the knee with flexion deformity of 20° bilaterally with a varus deformity of 10° on the right side and 15° on the left side with no limb length discrepancy in a 72-year-old male, general practitioner by profession, currently disabled with pain and difficulty in climbing stairs and squatting.
How did you measure the FFD?
Limb length.
Flexion
Flexion deformity. So I've measured the flexion deformity. First, I have checked that there is no lumbar lordosis, so that any hip.
I think lumbar lordosis has no bearing here. It is lumbar lordosis is bearing on the.
Yes, sir. In the hip. I've ruled out hip by that, and for flexion deformity, I've checked with the help of a goniometer by keeping one limb parallel to the femoral axis and one limb.
Are you carrying it?
Yes.
So show me how you align for seeing the FFD. Let's see on the right side. How you do?
On the right side, sir.
Are you having the goniometer?
Yes.
Okay.
Yes.
So for the benefit of everyone, and I think we would have asked him to present from the beginning. Okay, so that
I've asked the patient to do an active SLR type so that his hip is lifted out. Then I've placed with the help of an assistant, I've asked to hold the limb, and I've placed the one of the limb of the goniometer on along the femoral axis and one along the.
What if he's got a hamstring tightness then?
Sir,
you're doing the SLR, so the hamstrings are becoming tight because the origin is from the ischium and the insertion is to the tibia. So why you want to do SLR for measuring the FFD?
Sir, I just wanted to check simultaneously if there is any extension lag also.
That you don't have to flex the hip. No? Why do you want to flex the hip?
Where you brought the extension lag here? You keep the leg straight, no?
See, when you are taking it, you take him on the. See, this. Why do you want to do this? Sometimes there is a flexion deformity of the hip,
yes,
and then you are secondary. There may be flexion at the knee. So if you want to do that, you can take him. You can make him lie down like this. Let the knee hang, knee and leg hang, and then you check it. You can keep the thigh flat on the bed, and then you see.
Yeah. So having put the leg flat on the bed, what is the next step? For FFD.
Sir, the fulcrum I'll place the fulcrum at the lateral knee joint.
Thoda side mein aa jao. What is the error he is doing here? He just wants to do the FFD without doing any correction of the limb. What is he doing?
With patella facing up.
That's right. Patella should face up all the time. So make the patella face up. When you make the patella face up, the malleoli come in one line parallel to the floor. The lateral malleus is always posterolateral, right? So therefore, when you do that, both the malleoli will be at the same level. And then the patella will be facing up. So till the malleoli are parallel to the floor, you rotate. Is it parallel? Both? They should be.
Yes,
so therefore, the patella then will face
upwards.
Anteriorly, upwards, at right angle. Okay, then still the patella is lateral, I think.
See, in the external rotation deformity, if the limb is lying like this, your FFD will be concealed. No? The flexion deformity of the knee will not be apparent.
Most of these patients come with a combined varus and flexion deformity. So you have to separate one when we are checking the other. What's sir?
So this is how you see the FFD. Yes. Right? And why FFD is the beginning of the end of the knee? Why fixed flexion deformity of a patient is beginning of the end of the knee?
Because we can't do any joint preservation procedures.
I don't think you know that. See, what happens is that for extension, the knee has to be locked. For the knee to be locked, it has to be in full extension. And now because of the FFD, he cannot lock it because it is in flexion. So what he does, the patient will press the patella down on the femur. And that is how he lock it. And that is how the knee osteoarthritis will start. So FFD is the beginning of the end of the knee as far as osteoarthritis is concerned. So therefore, if the patient comes early with osteoarthritis, you'll find that there will be a small FFD. And if you try to correct that FFD, at least for some time, for many years or so, he will save the knee. So FFD is most important.
Why are you saying this is osteoarthritis? How do you substantiate that diagnosis?
I think let him tell us all the signs, no? A brief history and the sign.
Positive.
Positive.
FFD has gone.
Positive history and signs.
Okay, then
Examination findings. Start from the beginning here.
My patient, 72-year-old male, a general practitioner by profession, came with complaints of bilateral knee pain since the last 3 years and a noticeable deformity since the last 1 year. Patient was apparently all right 3 years back when he started insidious onset, gradually progressive, dull aching pain, bilateral knee, which was more on the right side as compared to the left side, non-radiating, which was initially started as intermittent pain, not restricting his sleep, but currently is continuous restricting his sleep, which is aggravated on climbing stairs, squatting, and partially relieved on rest and taking medications. Patient have noticed since the last 1 year, patient and patient's relatives have now noticed a progressive deformity with inward going of the tibia since the last 1 year. Patient has a history of hypertension and coronary angio bypass grafting done 12 years ago for coronary artery disease. There is no other joint involvement. There is no waxing waning of symptoms, no morning stiffness, no history of fever, weight loss, or no history of trauma.
there's no morning stiffness.
How
is that in arthritis? Ask him.
Sir, no significant morning stiffness because he has a stiffness for around 10 minutes, not more than 30 minutes.
Obviously, he'll have, if there's arthritis of the hip or if there's arthritis of the spine or there's arthritis of the knee, morning stiffness is bound to be there.
The pattern of pain, you said that the pain increases on climbing stairs.
Yes, sir.
What does that tell you in terms of arthritis?
Sir, it is a type of mechanical pain which is aggravated on doing activities and is relieved by rest.
No, I meant which part of the knee is more likely to be affected now that you're telling that it's more on climbing the
more of the patellofemoral.
patellofemoral. And if the pain was more on descending stairs?
Tibiofemoral.
Exactly.
So how does he climb the steps? Which side is more affected?
He has complaints of right side pain more than left side.
So how does he climb steps?
He has to climb with support.
No, one at a time, or he climbs just 1, 2, 3, 4?
Means one step, then he has to take the next step on the same step.
So which leg he puts first?
It does.
What? Ask him.
The good leg to the heaven.
Good goes up, bad goes down.
Goes down, yeah.
So good means he'll put the left leg up.
Less painful first and bad leg to the hell.
While climbing down.
The most painful while is climbing down. So that it is not in much flexion in wet bearing.
So good leg and he'll using a railing. He has to have a railing. He can't have a steps without railing. It can't be just a wall and just step that way. He has to have a railing. Then only he can pull himself up by both his hands, or by one hand by the railing and by the left leg. Okay. Proceed, jaldi.
Okay, clinical examination. Yeah. Findings.
I've examined the patient's supine standing and sitting position from front, side, and back. Patient is averagely built and nourished. Patient
local examination. Short case, local local.
On inspection, there is a patient is lying comfortably with slight flexion at the knee and extension at the hip with patella facing outwards. There is a varus deformity more on the left side as compared to the right side. There is a difference in the thigh girth, left side thigh girth more than the right side. Where
did you measure the thigh girth?
Sir, I've measured the thigh. On inspection, I've just noticed the decrease in the thigh girth as compared to the. And one
first question was exactly where do you, how much proximity?
Normally, where do you measure it?
Normally, sir, it is measured generally at the maximum girth, which is approximately 15 centimeters above the suprapular patella. Patient, he has a scar on the anteromedial aspect of the right knee, which is probably due to a bypass graft which was taken, which is healed by secondary intention. There is no fullness in the popliteal fossa. On palpation,
How you went to popliteal fossa in
Front
supine
is in-
position?
prone position.
You can't make that altum paltum that like the omelette and not. Patient has to be supine, then lateral, then prone. Popliteal fossa will
Front
come
is, are there
last.
any swellings? Is there any, how on inspection, what are the signs of effusion?
Yes, sir.
Ah.
I missed on the.
So
There's a
popliteal fossa
swelling.
you take in the end when you make the patient
Is there
prone.
any effusion
Yes,
on your inspection findings?
There's a
What will be
swelling
the
around-
signs of effusion in the inspection?
There is a swelling around the knee joint, bilaterally more on the right side. There is
Where all will be the
suprapatellar
same?
fullness with obliteration of the parapatellar fossa.
How do you measure that? How do you find parapatellar fossae fullness? In what position of the knee it is checked?
Sir, if for mild diffusion, we have to check in standing position, so that normally the fossa, the dimples can be visible prominently in a normal patient without any effusion along the patellar tendon.
Where, which dimples?
The parapatellar, besides the patellar tendon.
Patellar tendon.
No. See, what happens is that you have to flex the knee at about 60 degrees. Then what happens is the suprapatellar pouch will get emptied because of pressure and the parapatellar fossae will get obliterated. So see, flex. Both sides. Bas. It's 90. Make it less. Less. Bas. Now you find on the right side, left side, is there any difference?
Yes.
See that?
Attempted.
On the left side, the parapatellar fossae I can see, but on the right side, because of pressure on the suprapatellar pouch, the parapatellar fossae on the inferior side of the patella are getting filled up. Minimal effusion, you will get it in this manner on inspection. Okay.
Then,
So next.
is there any suprapatellar fullness?
Yes, sir. There is a suprapatellar fullness with obliteration of the parapatellar fossa on inspection. On palpation,
One second, sir. So inspection again is the,
there is no.
you have to
sign.
see from behind also. No, from front, from behind.
But posteriorly you go when you turn the patient. That is important because sometimes you would find that there is osteochondroma posteriorly and you find the knee is restricted, this, that, knee, you keep on doing and you miss the whole bus. So do that later on. And then Moran-Baker cyst.
Yes, sir.
Okay, chalo, come fast.
On palpation, I've confirmed my inspectory findings. There is no local rise of temperature. There is bilateral medial joint line tenderness. There is no tenderness over the tibial tuberosity or the femoral bony points. There is no scar tenderness.
Where is the maximum tenderness?
At the joint line, sir.
Where?
Medial joint line anteriorly.
Anterior. Where? Show.
How do you feel for the joint line? You can give a commentary, any comment. How do you feel for the joint line?
I will flex the knee, and then I will look at the. I will go around I will look at the tibial tuberosity and then go upwards, feeling the tibial condyle, and at one point where there is a dip, I will do flexion extension. And as I can see, there is a there is a joint like
you will feel it only at one point, or you will go around the knee?
No, I will
medially, posteriorly.
Yeah, I will go around the knee. I will mark one point and then palpate accordingly, going on both sides.
So now where is the pain? You have to watch the patient's facial expression.
In osteoarthritis, where you will get maximum tenderness?
Anterior side.
Anterior. So anterior horn of medial meniscus is gone. In a way.
It will be entirely, sir, a more.
Where it will be more medial and posteromedial. How anteriorly you are saying? There will be anterior horn of medial. Nothing happens over there. And you keep the patient's leg in external rotation this way. Keep it. Now there, see. Now you palpate inferior pole patella. Where is inferior pole? Patella.
Yes.
Now go medially. Palpate medially and medial posteriorly. Dukta ka tumhala? Huh?
Deep palpation.
You are palpating
You're not
in the
palpating strongly
vastus
enough.
medialis. That-
Also palpate the femoral condyles.
If he gets tenderness, I'll ask him second question. So he says there's no tenderness. See that? Now how it is painful? Because he's got. Ah. Yeah, that's it. How it is, huh? So medial side. You first start. You put the leg in external rotation, and from the inferior polar patella, you go this way, this way, this way, this way, and here, right? Next.
Patient has
What joint line tenderness is the sensitive sign for which pathology?
more for meniscus pathology, medial meniscus.
Very sensitive, yes, meniscus. And you may also feel the distal femur also. And many times there is a the crater there. Distal femoral condyle is also. So you can have the tenderness there.
Sometimes the differential is you can palpate directly on the bone on the medial femoral condyle. If there is an osteochondral defect, that can be a differential. I mean, we may feel that it's a medial joint line tenderness. The pathology may be in the femur.
Similarly, in the history, just to complete the history, you can ask when patient is telling you the history of pain, you can ask him to point, and whether he does it the one single finger, that is Bird's test as against the grab. Pain here, vis-a-vis here. So that differentiate between unicondylar and the triangle compartment. The patient holds the entire thing. You're asking where is the pain, so he will tell you this or here. So this is one Richard's Bird's one finger test.
Proceed. Palpation.
Next.
The swelling, the swelling on the right side is more than as compared to the left side in the suprapatellar fossa, which is soft in consistency, which is compressible, fluctuant, non-pulsatile, not adherent to the underlying bone, with no overlying skin changes, with a doughy feel. Patient, there is no scar tenderness over the scar healed by secondary
Tell us
lesion.
about that swelling. What is that? Swelling is
swelling.
synovium, whether it is fluid, what is it?
Sir, I've right now, because of the cross fluctuation test is positive, and I would there is a doughy feeling, so I would go in favor of synovitis, synovial hypertrophy, and the patella tap test is. एक मिनट ना थोड़ा टेस्ट करेंगे. I will first empty the suprapatellar fossa because it is communicating with it. And now, if there is a more gross effusion, then the patella will float up, and then I will two fingers.
Is it present in this patient?
No, sir.
No. So it is not present. That means the thickening and all the swelling is related to
More of synovium.
synovium. Correct. Good.
Further, ligament testing and all.
Yes. There is no lymphadenopathy. Bilateral popliteal pulses are equal.
No. Knee examination.
Knee examination. Lots of things remaining.
Knee examination. Complete the knee examination.
Special tests. There is ORS test is positive.
Is this deformity correctable or is it fixed?
There is
Is a coronal plane deformity, is it correctable?
It is not correctable, sir. Right now,
How did you examine?
I have
Is the flexion deformity correctable?
flexion deformity is correctable, not the varus deformity.
Sure.
Flexion deformity is
Completely
correct- then it is
correctable.
Sir,
Then it's not deformity, it is attitude. Is it attitude or
no,
deformity?
it's
See,
a-
keep it
there
in
is a
flexion
it's not
deformity.
correct.
Turn the leg
Not
inside.
corrected. Okay.
Turn the leg.
No.
Now, is it correctable?
It is not correct.
So he gets pain.
Okay. Now the varus, is there in, have you performed valgus stress test?
Yes, sir.
Show the varus
Valgus test, there is no joint opening.
In what, how much amount of flexion?
30
that we
degrees.
did?
I've checked in 0 degrees and 30 degrees.
Show me how
0
you do.
degree is not possible, no?
Yes.
There's a flexion
Maximum,
deformity.
Show me. MCL.
First, I've checked at around as there is a 20-degree deformity.
Hmm.
Then at 30-degree deformity.
Where are you giving
Where-
varus valgus stress?
So I've hold my
And
hold
your
above the
hand.
ankle, and then at the lower end of the femur, and then I'm giving a valgus thrust.
Okay. Why do you want to test this in this particular patient?
So it has a implication in the management, because we don't want to release too much doing soft tissue release. We don't want to release much. You can just move the osteophytes and then check introp if the deformity is correctable.
We're going far. Way far.
No.
Why do we get varus deformity in osteoarthritis? Why not valgus?
Sir, mainly the medial compartment is more commonly involved in osteoarthritis because it is more in line with the weight-bearing axis, which leads to exaggeration of the varus.
Any other reason for medial osteoarthritis, medial joint line getting affected first? Is the weight-bearing axis only reason? Are there any more reasons for medial joint line, medial compartment getting affected?
The medial cartilage is slightly less thickened as compared to the right side.
Other way around. Is thicker.
Meniscus is thicker. That is second. Any third reason? Pardon me? Density of the medial. No, more than that, it is immobile. Medial meniscus is immobile. Lateral meniscus is mobile. It moves with the femur because of the meniscofemoral ligament. So since it is moving along with the femur, it is less likely to get caught. The medial meniscus is immobile. So it can get caught, and you have medial meniscal tears are more common than the
And most important, the alignment in a normally aligned knee, how much is the load transferred in the medial side versus the lateral side?
See the
Perfectly.
60% on the medial side.
So the weight bearing is opposite S2. So it is like this. Okay. So now when I am standing unilateral stance, now still the weight bearing will be more on the medial, and the knee will tend to drift into varus, which is prevented by my lateral muscle contraction. So normally with the normal alignment, tibiofemoral alignment, with 7 to 8 degrees of tibiofemoral alignment, 60% of the weight is borne by the medial compartment and 40% by the lateral compartment.
And why is the varus knee more painful than a similar extent of valgus knee? 20-degree varus versus 20-degree valgus, say. Varus is more painful. Why?
Normal alignment is a little valgus. So
No, actually, because the reason is mechanical. Normal weight bearing favors the medial side, as we discussed. If the patient has a superadded varus deformity, there is edge loading on the medial side. The weight bearing axis, the mechanical axis, further shifts medially. So there is edge loading around the medial side, and that leads to pain. If it were a valgus knee, the weight bearing axis would shift in the broad part of the lateral femoral condyle. So the pressure would be distributed over a wider area as compared to the medial side. Medial side, there is edge loading. And that is the reason why varus knee is more painful.
Pain is also related to the joint reaction forces, which is proportional to the amount of muscle contraction. Okay. So as I told you, if more the varus, there is to keep it in valgus, we'll have the biceps, the IT band will have to contract stronger. Still, you are not able to correct. But the joint reaction forces which are created are far, far greater as compared to that which would occur in the valgus knee, because medially there are not stronger muscles as compared to the lateral side. Yeah. The joint reaction forces of that the load passing across are related to the joint reaction forces. Okay.
What are the causes of flexion deformity in osteoarthritis? Your patient has flexion deformity. What are the causes of that?
Both. Causes of flexion deformity and causes of varus.
the causes will be soft tissue causes, soft tissue contracture. The posteromedial contracture will cause flexion deformity. Also, the pattern of the osteophytes, if it is impinging, not allowing complete extension. So initially there will be impingement and later on contractures.
So more than a contraction is tethering. The osteophyte is a body's reaction to increase the surface area to distribute the same load across larger surface areas so that stress per unit area is less. But then in effect, what it causes is stenting of the superficial deep and superficial medial collateral ligament. That causes tenting. That is the first cause. Second, over a period of time, what will happen is there is bone loss and scalloping. So second cause is also because of the bone defect. Okay. Same thing occurs in the
Initially, it will always be effusion, and gradually everything else. The first for flexion deformity will get is because of effusion, and then gradually all this come into picture.
If the flexion deformity is not correctable by force, and if there is a sharp bony bump to it, what does that indicate? What will you find on the X-ray?
There can be an anterior osteophyte,
Anterior.
which is impeding the extension.
Where? It will act as a hinge stop. No. Sir, just answered your question before.
Usually, there's a
Because the
posterior
tenting of
osteophyte
the-
which is tenting that.
Tenting of the osteophyte.
Can you go ahead with the examination findings? Anything else?
The on movements, there is a flexion deformity of 20 degree bilaterally, with further flexion possible up to 110 degree on the right side as compared to 120 degree on the left side. There is a movements are terminally painful, associated with crepitus throughout. There is no patellar maltracking. Patient, there is a patellar grind test is positive. Patient is having there is a medial facetal tenderness on the right side. There is no patellar apprehension test is negative. Meniscus signs are negative. As checked by
The joint line tenderness is a meniscus sign, no?
other ligaments signs are negative. ACL, PC.
You meant McMurray's meniscal.
Sorry, sir. I wanted
No,
to say
just calm down,
ACL.
calm down. If you are not relaxed, you will make further mistakes. So just calm down. When sir asked meniscal sign means he was
Yes, I
asking about
wanted to say
McMurray's test or
McMurray's and ACL and PCL tests. Blackman anterior drawer. ACL, sir. First, I did a Lackman test on the right side. I will just flex the knee around 20 degree. Keep one hand over the tibia and one over the femur, and then try to anteriorly subluxate the tibia over the femur.
How much is the rotation of the foot? The Lachmans? Foot rotation?
Should be facing upwards.
In the drawers, how much should the foot be in neutral position?
We have
external
to check
rotation?
in 3 positions. In the neutral position, and on internal rotation it will be decrease, and on external rotation it will increase.
so the Lockman test that you showed. If the patient is bulky, there is another easier way to do it. Do you know this?
Yes, sir. We can keep one leg over this, and then try to anteriorly subluxate.
Can I show it? Maybe I'll show it on this side. So first, keep the thigh like this. Relax the leg. Rotate the hip like this so that the muscles are as relaxed as possible. And then grab the leg with your orthopedic hands. Give a counter pressure here and just do this test. Can everybody appreciate that? Okay, so the anterior translation of the tibia in ACL laxity or tear is more easy to elicit in the Lockman test than in the anterior drawer test.
Some time back we asked you about the valgus stress test.
Yes.
So we left out at that. What was the significance in doing this? Because this is not a traumatic etiology,
No, sir.
is it?
No,
So
sir. It is not a
why
traumatic etiology.
are you doing a valgus test? In traumatic etiology, the implication of valgus test is different. No?
Sir, I actually have.
In this, it is different. Why do you want to do it here?
If we want to see whether we want to know the ligament, collateral ligament status by doing a varus valgus test, so that
See, that is in the traumatic situation. This is a degenerative arthritis, degenerative knee, right?
there will be a laxity
Corrective.
on the lateral side.
Valgus test, what do you see? Valgus test, what do you see? That you are testing lateral side or
Medial side by
Medial side.
valgus.
So
Then partial correctability of the.
why do you want to see the correctability? That is what I'm asking. Suppose it is correctable and a situation where it is not. Is it correctable here fully? Is
No,
it
sir, not
correctable to neutral? Is it correctable beyond neutral to
It's not correct.
Normal
It's not
valgus.
completely correctable.
why do you want to know that? Does it have, no, I'll give you a clue. Does it have a management implication?
Sir,
If it is correctable vis-a-vis, if it is not correctable.
well, if you want to do a total knee replacement or a single unicondylar,
So if it is correctable, it is perhaps,
we can do a stress
It is,
X-rays
yes,
at 20
yeah.
degrees and then see.
okay, go ahead with the examination. We are left at the exam. Interrupting you in between. Go ahead with where you are left.
On measurements, the right side tibiofemoral angle is 10 degrees as compared to the left side 15 degrees. There is a difference in the
Tibia femoral angle is 10 degree of varus.
10 degrees
Okay.
of what? Varus.
Mention that. Normal
Yes.
is
No, valgus. Normal is 6 to 7 degree valgus. The bilateral Q angle is 14 degrees. There is a difference in the limb length, girth of the thigh of around 2 centimeters with left more than right, and around 1 centimeters in calf left more than right. No limb length discrepancy.
With this much of knee deformity, did you check for any compensatory ankle deformity?
Yes, sir. Ankle movements are.
Should you check?
Yes.
In long-standing arthritis, sometimes there is a compensatory ankle stiffness and deformity, which you must take into account.
Then the other joints are not involved. Are normal. Bilateral hips are normal. There is no lower lumbar spine is normal. There is no distal neurovascular deficit.
how is the
Yes, sir.
Popliteal, yes.
Popliteal surface, there is no swelling in the popliteal fossa. There is no popliteal lymphadenopathy. Bilateral
is there any
popliteal.
cyst, popliteal cyst?
There is no popliteal. There is no swelling.
What is Moran-Baker's cyst?
So it is outpoaching of the synovium through the posteriorly through the oblique popliteal ligament, or which generally is around the middle part of the knee joint, which is more prominent in extension.
Is it semimembranous bursitis or something else? What is the difference between Moran-Baker cyst, popliteal cyst, semimembranous bursitis?
So the location of the semimembranous bursitis would be more on the medial side. Moran-Baker cyst will be morely in the
Posterior.
center.
So what is the cause? Suppose we have cyst there. What is the cause?
And it can be secondary to a degenerative pathology.
It is usually secondary. It is in adults unless proved otherwise. So we don't go and do the popliteal cyst excision because it is always secondary to the internal derangement of the knee. Yeah.
Knee joint.
You forgot to mention the gait. How is the gait of the patient?
Patient is walking with bipedal unassisted with a lateral thrust.
Can you demonstrate that lateral thrust and its clinical significance? You also tell.
चालू नका ना.
थोडं चालू
असं वरती एक
थोडं
वरती
चलके
पकडा.
दिखा.
गुडघे बोलतो. What is the significance? What is the clinical significance of this?
So there is along with the varus deformity, there is also a lateral ligament laxity, which is increasing the varus with every step he's taking, and that ultimately there will be complete stretching of the collaterals of the
Lateral thrust is usually because of the attritional rupture of anterior cruciate ligament. Here you may not be, unlike a traumatic situation, your Latchman and anterior drawer may not be present because of the osteophytes. You may not get those classical drawer tests, but the lateral thrust itself, lateral thrust is lateral subluxation. Tibia would perhaps see a lateral subluxation of the tibia. And that suggests that anterior cruciate is gone. That means it's not only medial compartment, but now it is intercondylar region also. There are attrition, the osteophyte, which has amputated the ACL, attritional rupture, and it has also spread to the lateral compartment. Now it is at least bicompartmental, and you did grinding of the patella, so it is now tricompartmental osteoarthritis. So can you summarize your diagnosis?
My patient is a case of bilateral tricompartmental primary osteoarthritis with a flexion deformity of 20 degree bilaterally with a varus deformity of 10
Flexion
degree.
deformity at 20 degree with further
Further
flexion. This
flexion.
one is not correctable. Varus not correctable. Rigid deformity. All these have to come.
Further flexion possible up to 110 degrees on the right side as compared to 120 degrees on the left side, which is and a varus deformity of 10 degrees on the right side as compared to 15 degrees on the left side, which is not completely correctable. Patient walk with a patient having currently disabled with
Having antalgic gait. Mention that antalgic gait. What would you like to do for this?
I would like to examine. I would like to investigate the patient radiologically and hematologically.
You tested his flexion in supine, sitting, or prone?
Sir, I've tested in supine position.
No, because then you will be relaxing the quadriceps. You see how much flexion you get in supine? Show me now.
First, I will check for active flexion. Chacha,
No, you just do it quickly, huh? How much it is? Don't press.
It is painful in terminal.
You must not give pain to the
Terminal, it is
patient.
not. He's not going beyond 90.
So
Is it
this
having
much,
90 more
right?
than 90?
Okay. Now make the patient prone.
गुडघा वाकवा अजून
जरा तुम्ही आता उलटे झोपता का पोटावर? हाँ, एकदम उलटे झोप. सरळ.
This is not terminal. This is only 90 degree
Okay.
section.
Now show.
It's deep.
Range of motion only 90.
It is not terminal. Terminal means it patient is having up to 120 degrees.
120.
This is not terminal.
Show now. Show the
Now
flexion.
show which side is more. See that?
90.
Now it will be that.
90 maybe just
That is because the quadriceps are not relaxed.
Relax.
So this is how you test the flexion. Otherwise, he'll be able to do this much. You'll say it is 120, but that is not so. Okay, X-ray. Saral Gupta. Stand.
This is a plain X-ray of left and right knee, AP, and anteroposterior and lateral view. We can first. I would like to comment on the left side. There is.
I think see. Okay. So right side. Describe right side.
describe the right.
There is decrease in the lateral as well as medial joint line, joint spaces. There are multiple osteophytes seen on the tibia as well as on the femur. There is lateral subluxation of the tibia around one.
Where?
Lateral subluxation of the tibia
The right knee?
in the right knee.
Not significant. Okay.
Not significant. So when you describe the osteophytes, you have to mention the location. And most important, you forgot to mention that the X-ray is erect, weight bearing. So that has a huge clinical implication.
On the lateral side also, there is patellofemoral arthritis with we can see the osteophytes on patella as well as on the anterior surface of the distal femur.
Can you comment on the patellar height?
Patellar heights are ideally should be commented on a 30-degree flexion view lateral
It
side.
is 30 degrees.
It is actually normal because the lower pole of patella is at the level of the Blumenstedt's line.
No. So what is it? Does this confirm your diagnosis?
Yes, sir. It is confirms my diagnosis of a tricompartmental osteoarthritis bilateral.
How would you treat this patient?
As
do
the
you want to
patient, 72-year-old.
What do you want to do?
Sir, as a 72-year-old male, he has already taken some medication, but he is only partially relieved. I would like to advise the patient for a surgical intervention in the form of total knee arthroplasty.
Why not a unicompartmental knee arthroplasty? He has more symptoms, pain, tenderness in the medial side.
No, before
Sir,
jumping, I think for the benefit of all, I think you go stepwise. What would your general non-operative, then operative, rather than jumping directly on this? No, you don't know what he has taken treatment. So what are the different medical line of treatment for this?
So we can start with NSAIDs.
What NSAID?
You want to give anti-inflammatory or just
NSAID. What NSAID?
NSAID can be acetaminophen.
Acetaminophen is not NSAID. There is paracetamol, no?
paracetamol? You want?
Then that is NSAID. Non-steroidal
It's not inflammatory, no, it's not
drugs
inflammatory.
means what? What are the A's?
This is not inflammatory
Name
arthritis. No?
3-4.
This is not
NSAID.
inflammatory arthritis. Non-inflammatory arthritis. Why do you want to give NSAIDs?
Diclofenac,
So
paraffenac.
can you give diclofenac, aceclofenac, paroxicam, lonoxicam? Can you give etodelac? Can you give him? No, you don't. You can't give a patient any NSAID after the age of 60. Why? What are the complications of NSAIDs?
Renal, chronic renal.
Only renal.
Gastric.
Renal, cardiac, gastric, hypertension. And this patient already has a bypass.
Simple paracetamol will do. Then what else? What other drugs? Slow symptomatic, symptom relieving drugs. Have you heard of this class?
This patient has got a bypass.
Supplement. We can counterprotective agents like
What are these?
hyaluronic acid and
Hyaluronic acid orally.
hyaluronic.
Slow symptomatic, symptom relieving drugs.
Chondroitin sulfate.
How do they act?
They act have a chondroprotective mechanism which decreases the cartilage wear and
Glucosamine sulfate and
glucosamine sulfate, which
chondroitin sulfate.
increases the proteoglycan.
What are interleukin? Are there any interleukin inhibitors available? Yes. So how do they act?
They act on the inflammatory pathway, decreasing the interleukins, which are
Any other splints, braces, aids, walking aids? Would you like to advise? Footwear aids? Would you like to advise? Oh, you have to go symptom. This thing. What are rubifications?
they act on the gate pathway, which causes
Gate pathway.
gate alteration of the because of the pain can be
Pain pathway. Gate pathway.
Not gate, pain pathway.
Will viscosupplementation help in this patient?
Role of viscosupplement. What is the grade of this? Kellgren-Lawrence grade or
Kellgren-Lawrence grade 4. So less likely there can be the benefit from a viscosupplementation.
how do they act? Viscosupplementation.
Viscosupplementation has it can act as from various routes. It is also a counterproductive agent. It also has some anti-inflammatory properties. And also it decreases the matrix metalloproteinase.
So don't jump on directly on the surgery. First, you local physiotherapy. What is the role of physiotherapy? How does the stick act? Would you advise him take stick?
Stick in which hand?
The less painful.
Less. Left hand.
Less.
Hot fomentation, cold fomentation. How does it act? Would you advise hot fomentation, cold fomentation? What cold packs? What would you advise? And if you are advising, how do they act?
Offloading braces.
Offloading braces, but
Will they help?
tri-compartmental osteoarthritis. No, it won't help because we can't offload because all three compartments.
It is not one, and it is not correctable deformity. It should be. It's 3-point pressure. Okay. Earlier, any change in the footwears?
Lateral side, we can increase the height so that the varus deformity can be.
All these have to come, and then perhaps the role of the surgery. So surgery in the form of what?
Total knee arthroplasty.
Total knee orthoplasty.
Okay. So
Now one more sign is there. Now let's see if you know that. Patient comes with pain in the hip. When he's sitting that way, he's getting pain in the hip. Pain in the hip. So then the physiotherapist and unknowing persons will keep on treating pain in the hip. What is this sign? Pain in patient is sitting here, getting pain. He can't do that.
Radiating pain to the hip, the knee joint.
Anybody knows? Or I'll tell you. If the patient is not able to sit in a figure of 4 position like Sri Sai Baba type, it is a posterior horn of medial meniscus. Very often this is missed. Very often it is mistreated as pain in the hip. And you will find that on the other side he can do this, which is normal. But on the affected side, he will sit like this. Moment you start doing that, the knee will flex and the posterior horn of medial meniscus will get trapped and he'll get pain in the hip. This is the sign for posterior horn of medial meniscus. Okay.
We shift on next. Who is present?